Bienvenidos a Revista Sin Fronteras. Hoy les traemos un invitado muy especial. En nuestra sección en Hablemos de nos encontramos con el Doctor Manuel Fortes. Él es neuroradiólogo, quien nos va a hablar de los aneurismas. Nos va a decir su método de diagnóstico y nos va a hablar de sus tratamientos. Welcome to Revista Sin Fronteras, Dr. Fortes.
Thank you, gracias. So aneurysms are like a blister in a vessel wall, and they're most common in the brain, and those are the ones I treat, the brain aneurysms. So usually it starts as like a weak spot in the vessel wall, that because the arteries in the human body are pressurized by the heart, so each time the heart pumps blood, it does that with pressure. That's why you can feel a pulse. That's why you have, high blood pressure sometimes. So the arterial system is pressurized, and so arteries have a thicker wall than the other vessels we have in the body, which are the veins. And then if you have a weak spot in an artery, over time that starts to push out like a blister, and that vessel wall stretches out, and that's called an aneurysm. Well, most of the aneurysms, we don't know the exact reason for them to exist. We know that it starts as a weak spot in the vessel wall. But what causes that vessel to be weak in that area in the first place? Most of the time we don't know why. Some patients have some diseases like collagen disease, Ehlers-Danlos, and other types of collagen diseases that can increase the chance of having aneurysms. In other patients, aneurysms run in their families, so there's probably a genetic cause for them, but most of these genes we haven't identified, so we can't pinpoint a specific reason, so we just call them random or incidental. About anywhere between 2 to 5% of people probably have an aneurysm, and they don't even know about it. So you can see aneurysms in the brain either by doing a CAT scan with contrast, it's called a CTA of the head, or an MRI of the vessels of the head, it's called an MRA or MR angiography. I think the MRA is best because it doesn't require radiation, so it doesn't expose the person to radiation, and it doesn't even require contrast. So it's just you just go there in the machine and have your head scanned, and then you can find out if you have an aneurysm or not without radiation or contrast. Well, if you do a CT of the head without contrast, which is the most common CT of the head to be done if you go to the ER with a severe headache, or if you I think the most commonly done brain test is the CT of the head without contrast, and that's not going to show an aneurysm. Unless it's a very large aneurysm, it's not going to show up on the CT without contrast. So to see the aneurysm on a CAT scan, you need the CT angiography, which is with contrast. And same for the MRI. If you just do a regular MRI of the brain, it's only going to show very, very large aneurysms. To see any aneurysm, or all of them, you need an MR angiography, which is same machine, but it's a different test. Well, if you're having headaches that you can't really explain why, perhaps a good idea to have an MRA of the head done. Or if you have a family member like a mother or a father or a grandparent or siblings that have aneurysms, it might be a good idea to do MRI of the head in the, in those family members. Well, the MR angiogram is just you do an MRI of the head, and the MRI machine is set up in a way for that study that it follows the blood flow in the blood vessels. And so it creates a very good image of the blood vessels, the arteries in the brain, by following the blood flow. So that's how it's done. A CAT scan, which is a CT angiogram, is done by injecting contrast in the vein, and that contrast mixes up with the blood everywhere, and then that contrast is really bright on the CAT scan, and also again forms a image of the vessels in the head. The other angiogram, which is for someone usually that already know that they have an aneurysm and need to have a better look at it, to see the size perfectly or to decide what's the best treatment option for them. And then that's a catheter angiogram, and that's done usually at the hospital, usually with sedation. And then in that study you put a catheter, which is a long floppy plastic tube, through the vessel either at the groin or at the wrist, and then you navigate that catheter to the vessels in the head and inject contrast dye and take very magnified X-ray pictures of the head. So that's the gold standard or the best study, but that's only reserved for someone that already knows they have an aneurysm. All right, so aneurysms in the brain, I think they've been known to exist for a long time. And the first time somebody thought about a way to treat the brain aneurysms, I think it was in 1937. They did a clipping of a brain aneurysm at Johns Hopkins, Dr. Dandy. So he was the first one to do that. And so they opened the skull, and they were able to see the aneurysm, because the aneurysms are brain aneurysms, but the vessels in the brain, they are not, the bigger vessels are not inside of the brain, they are on top of the brain. And so when you open the skull, you can see those big vessels where the aneurysms are. So you see the aneurysm, and then you can put a clip across it, and that works to fix aneurysms. But for many years, that was the only way to treat them. And then in the early 90s, this neuroradiologist, Dr. Guglielmi, I think was his name, at UCLA, he did the first coiling procedure for aneurysms, or coils embolization, in which instead of opening the skull, he just went through the vessels, through the arteries with a catheter, and put microcoils inside of the aneurysm to block it off from inside instead of treating it from the outside. And nowadays, up to 90% of aneurysms are treated endovascularly, or going through the vessels, and only a minority, maybe 10% or less, are treated opening the skull and putting a clip. So even though the majority of the aneurysms are treated endovascularly, going through the vessels, there is still a role for open surgery and clipping. For some aneurysms that are more complex, the main thing that would make an aneurysm be a good candidate for clipping is if there are multiple arteries coming from the aneurysm. So most aneurysms are just like a little sac or a blister, but some of them might have a vessel coming from here or from there. And in that case, if you fill it up with coils, you're going to block off those vessels and cause a stroke. And with a clip, the surgeon can kind of see those branches and avoid them. So for those type of aneurysms, clipping is still the better. But those patients are going to get an angiogram first because it's a minority of patients. So all aneurysms are going to be followed forever. Usually they're in the beginning of the follow-up period. You follow them up with angiograms, like catheter angiograms. And then once once they look good and things are healing properly, then you move on to follow up with MRA, with the MR angiography of the head every 2 to 3 years. And you're going to be doing that forever to make sure it's not recurring or coming back. Now, so clipping usually is pretty permanent. It doesn't tend to recur. It can rarely, but it's pretty permanent. So that's the good thing about clipping. The bad thing is that it's very invasive. You have to, do open surgery. Coils, when you put coils inside of the aneurysm, there's about a 10 or 15% chance of recurrence. The method that truly reconstructs the vessel and makes the vessel kind of brand new and fully healed is another treatment option that was developed later on even. It's called flow diverter stent. And the first flow diverter stent that was available in the United States was called pipeline embolization device, and that was approved by the FDA in 2011. And that was really revolutionary. It has some very good advantages. One of them is that you don't have to touch the aneurysm itself. You put the stent, which is like a little tube of metal, inside of the blood vessel next to the aneurysm without having to touch it. And so that decreases chance of the aneurysm rupturing during the procedure because you don't have to touch it. And another advantage, it's like a scaffolding for the blood vessel. So the blood vessel over time grows inside of that stent, and the aneurysm just goes away, and the vessel looks brand new after several months. Takes several months to fully heal. But for that particular treatment option, which I like a lot, once the aneurysm is gone, it doesn't come back. It just takes longer for it to fully heal, but once it's healed, it's done. Yes, unfortunately, when you do clipping, you can, it's a very, very thin wall. Because you gotta remember, originally it was just a little weak spot in the vessel wall that started to grow out. So that tissue is very stretched, very thin. It's like wet toilet paper. It's very, very thin and fragile. So it can happen then when you're putting a coil in, that coil stretches the aneurysm a little bit and it can bleed. And if that happens, you have to kind of work around it and stop the bleeding. But when you do a flow diverter stent, that risk is minimal because you're not really going inside of the aneurysm. You're just being next to it. Well, once you put the stent in there, if it's a flow diverter stent, then there is much less blood flow going into the aneurysm. So it would be very, very rare for that to happen. Same with the coils. If you put coils in it, then it's much more protected. And then if you do the follow-ups and make sure nothing rare is happening, then that risk would be very, very minimal. Yes, so the neuroradiologist is a radiologist, and back in the day, perhaps 20, 30 years ago, the CT angiogram was not a very good test. The CAT scans were limited in their resolution, the images were not very good. And so anytime you wanted to look at the brain vessels, you had to do a cerebral angiogram with a catheter. And radiologists did that test back then. And so they were the ones, diagnosing the aneurysms before a neurosurgeon would do the clipping. And at some point, some of them, thought about, well, what if we can, treat these aneurysms, from the inside, just like we do, stents for the coronary or for the carotid, for the legs. And so the first coiling was done by a neuroradiologist at UCLA in 1991, Dr. Guglielmi. He developed the first coils, called the GDC coils, called Guglielmi detachable coils, GDC. So those you put the coils in the aneurysm and then use an electric charge on the outside to detach them. And that's still how it's done now, but now it's much faster and the device is much smaller on the outside, but the principle is the same. So that was all developed. So basically this field was developed by interventional neuroradiologists. The pipeline, which is the flow diverter stent, was developed by Dr. Peter Kim Nelson. He's from NYU, and he's also a radiologist. So the endovascular field was developed a lot by radiologists. But yes, neurosurgeons and neurologists also do these procedures. But I would say that radiologists were the ones developing this technology since the beginning. Perhaps because we don't do surgery, so we had to kind of think outside the box to treat it differently. If they do the training, and they can do, and several of them do, in our group here, Orlando Neurosurgery, it's 5 of us doing this type of procedures. 2, myself and Dr. Hellinger, are radiologists, and then we have 1 neurologist and 3 neurosurgeons. I guess it's 6 of us. Yeah, for sure there are. I've seen challenging cases. I've seen aneurysms that were like 5 centimeters and needed several stents together to reconstruct a vessel. That can be very challenging. It's also very challenging when you have a very big aneurysm, and anything 1 centimeter or more we call a giant aneurysm. Even though it's just a centimeter, it's giant. So if you have a giant aneurysm in a very small vessel, kind of far away, that's challenging and very risky to do. We do those, for sure. Yeah, I've seen all kinds of things. Well, if you have 1 aneurysm, you have a higher chance of having another one than somebody else. So if you have an aneurysm, you have about a 20% chance of, developing or having a second one. So when someone has an aneurysm, we do an angiogram and look at all the vessels to make sure there's not another one that, we didn't see. The most I've seen in one person is 9. But I think most patients have 1 or 2. I mean, most patients have 0, but I guess 1 or 2 is pretty common. And more than that is more rare. Yes. So aneurysms, until they rupture, they usually don't cause a lot of symptoms or trouble, really. The problem is that if they rupture and when they rupture, it's very bad. It can kill a person instantly, and half of the patients that unfortunately have aneurysms ruptured, they die instantly, and the other half come to the hospital, and then we have to treat them emergently. The problem with the emergency treatment is that you don't have the same options that you do when you do elective. So if you find an aneurysm before it ruptures, there are many more options to treat in comparison to when it's ruptured. So typically the flow diverter stents, which I think are the best treatment, you can't do that if they're ruptured, because the patient has to be on blood thinners to get a stent. And you can't really give blood thinners if they have a ruptured aneurysm, because it's going to make it bleed more. So you're limited. You either have to put coils or you got to do clipping. If a person was having, for example, headaches, which is a common thing from aneurysms, once you treat it, it tends to improve over time. If you put a flow diverter stent, the aneurysm only truly fully is gone in about 6 months. So you could have some symptoms, lingering, after the treatment, but it should be getting better over time. It certainly should not be getting worse. Other things that can happen if you have an aneurysm, you can kind of press on a nerve in your brain and cause, for example, double vision or other things like that. So those should also improve over time. Right, so we can't change the genetic component. But one thing we know make aneurysms grow and also increase the chance of them rupturing is cigarette smoking. Alcohol in not a little bit, but if you do like binge drinking, drink a lot every day or heavily sometimes, that can, because it can affect the health of the blood vessel wall, and that can make that vessel wall weaker, and then the aneurysm can grow or rupture. If you have high blood pressure and it's not controlled with medication, because remember I said, so the heart's pumping blood every second, you have your heartbeat every second, and that makes slowly the aneurysm grow. If you have high blood pressure, then it's more pressure than normal, and so if you have a weak spot in a vessel, high blood pressure can make the aneurysm grow. Yeah, so well, if you have a ruptured aneurysm, we don't give any blood thinners. But if the aneurysm is unruptured and elective, scheduled to be treated, then most of us, and I do that too, put all patients on blood thinners. Typically Plavix and a baby aspirin. And then if the patient does not respond to Plavix, we give something else called Brilinta, which works the same. So we do that before surgery, and then if a stent is not used during surgery, then they can stop the blood thinners immediately after surgery. And then if a stent is used, either a regular stent or the flow diverter stent like the pipeline, if that's used, then you gotta be on that blood thinner for 6 months. And that's to allow for the healing process to happen in a controlled fashion, so that clots don't form in the vessel and you don't have a stroke. And if you take the blood thinners for the 6 months, then almost always is fine. Because after several months, the blood vessel is gonna grow inside of the stent, and the stent's gonna become a part of the blood vessel. And so the blood inside the blood vessel will not be touching the stent directly. So if you have a stent you just put in today, when you put the stent in, the cells in the blood are going to see that as something that doesn't belong to the body. And so if you're not taking blood thinners, you're going to form a lot of clots in it, and that's going to cause stroke. And that's why we give the blood thinners, so that that doesn't happen, there's no stroke, and allows the body to heal and the blood vessel to grow inside of the stent. And then once the blood cells are not touching the stent anymore, then they won't form clots anymore. So it's safe. I think it's a very exciting time, for us and for patients with aneurysms. So a lot of change and new technology is helping patients significantly. Before 2011 or 2012, you didn't have the flow diverter stents. The new thing that's coming out now is called intrasaccular devices, which are very interesting, and I think they're going to be coming out much better devices in the next 5 to 10 years. Those are devices that have the same type of technology as flow diverters, but instead of being a tube like a stent, they are little spheres that you can put inside of the aneurysm. Just like you put a coil, but this is much better because this reconstructs the vessel just like a flow diverter does. And so perhaps this is going to lead to less recurrence and better healing of aneurysms. I think 5-10 years from now we're going to be doing clipping for even less aneurysms than now, even less than 10%.
Quiero agradecer al Doctor Manuel Fortes por estar aquí con nosotros, compartiendo mucho de su conocimiento y su experiencia tratando los aneurismas. Usualmente nunca hablo, o los periodistas no hablamos de cosas personales en nuestras entrevistas, pero en este caso voy a aportar, se puede decir, con mi experiencia. No les había contado, pero pues soy paciente del Doctor Manuel Fortes. Estoy muy agradecida porque siento que me salvó la vida, literal lo siento así. Es una persona que definitivamente siento que me dio una segunda oportunidad, porque me enteré que tenía 6 aneurismas. Él fue el que me los detectó y me los trató. Por eso me pareció muy importante hacer esta entrevista, porque hay mucho desconocimiento sobre el tema y sobre todo de la ciencia y cómo se está poniendo realmente a favor de este tipo de procedimientos que uno los consideraba demasiado invasivos. Estoy demasiado agradecida con el doctor.
Thank you so much.
Con la forma como los médicos están tratando de salvar vidas y ayudar a pacientes como yo a que podamos tener una segunda oportunidad y podamos seguir desarrollando estas actividades como periodismo y tantas otras, y seguir viviendo y poder disfrutar de este ejercicio, este trabajo que estoy haciendo y que trato de llevarles en cada edición de Revista Sin Fronteras en Hablemos de. Y pues como les digo, hoy nos acompañó el doctor Manuel Fortes. Mil gracias, doctor, por su amable y su bondadosa obra que está haciendo con todos nosotros, todos tus pacientes.
Thank you so
Muchas
much.
gracias.
Thank you for the interview.